All right, hello everyone. My name is Zuhair Zaidi, and I'm with my co-host Saad. And today we have a very special guest with us, Dr. Nayyar. He is a hematology and oncology physician, and we're going to be asking him a couple questions today about his medical practice, how he got into medicine, and if he has any career advice for us as we try and pursue our own path into medicine. And so I want to thank you all for joining us today. And I'm going to go ahead and start off with Dr. Nayyar's bio, and then we'll move on from there. And so, Dr. Nayyar Sayed is a board certified hematology slash oncology physician at Texas Oncology in Mount Vernon and Mount Pleasant, Texas. He earned his medical degree at Dow Medical College in Karachi, Pakistan, and completed his residency at the University of West Virginia and the University of Oklahoma, as well as his fellowship at the University of Texas Medical Branch in Galveston. And so that was his biography. And now I'm going to switch over to the definition of his specialties that are provided by the Association of American Medical Colleges. And so hematology and oncology is a subspecialty of internal medicine, and it involves physicians who are trained in the diagnosis, management, and treatment of patients with a wide variety of blood and neoplastic disorders, as well as many organ-specific cancers. And so now I want to hand it off to Dr. Nayyar, who is with us over the phone, and I want to ask him if there was anything he'd like to add or subtract to the biography or the definition of your specialties to actually describe them.
No, I think you did a good job, and bio is correct.
Okay, awesome. Thank you for that.
All right, perfect. So, Dr. Nayyar, our questions are split up into three parts. So the first part of our questions revolves around your own journey to medicine. So I'd like to start off by asking you, what drove you as an individual to become a pre-med and pursue medicine?
Okay, so it's going to sound cliche, but it's very true that from a very young age, I wanted to be in medicine now or healthcare, and even I can remember 7th or 8th grade when people ask me, what are you going to do when you grow up? Everybody asks you that question. I told clearly everybody that I want to be a doctor. Now, I didn't know what type of doctor and all that kind of stuff. I was very interested in botany in the beginning. When I was a kid, I would look at plants, and we had a lemon tree at our house in the backyard, and I took care of all the plants in our house. And I remember I would cut a slide, a leaf of the lemon tree, and I would, put it on my microscope, and I just enjoyed looking at life under a microscope. I wasn't very much into zoology, but more botany. But as time went, I knew that anybody who gets into botany later on ends up doing zoology, and that person ends up becoming a doctor. So I have always wanted to be. I guess the flip side of that is that I hated mathematics. I know that's not a good reason, but I liked physics. I liked chemistry, the organic chemistry. So what happened is what happened to me is, because of my early tendency towards, healthcare, everybody around me just kept on talking about it, and they started to call me Dr. Nayyar when I was so young. In a strange way, it kind of puts pressure on you gently and out of love that you want to do that now, because not only I think about it, everybody else thinks I'm going to be a doctor. So that's my story. Nothing to learn from it.
I think that's very informative. Thank you. So our second question is, how was applying to medical school for you like? I know your situation is a bit different than what the average pre-med here is used to. So if you could reflect on that, and if there are any tips you'd give to students like us applying to medical school.
Yeah, so you're right, and I had mentioned that is very true. Our systems are very different. In Pakistan, we use the British system, and so it's totally different world. Basically, in Pakistan, in 12th grade, based on your scores, the top some percentage students, are selected in medical schools, and then among the medical schools, and there was no Aga Khan Medical School at that time, which is now the #1 medical school. There was only Dow Medical College, Sindh Medical College in our city. So the top ones, based on the score in 12th grade, went to DMC or Dow Medical College, and the next batch went to SMC. So it was very simple, just as simple as that. There was no, I do believe that getting into medical school in the U.S. is so difficult. I don't know what I would have done, MCAT and all of these things, not just the examination performance, because that's what it was for us, just the performance in your 12th grade exam. There's no essay writing, none of that. And that's why I think it's really hard. I feel bad for students here in the U.S., but that's the difference. I don't know if my experiences be of any benefit to someone applying here, because the rules were different and the requirements were totally different.
Okay, yeah, that's fine. So we can just move on to our next question after that. So why did you choose to become a physician as opposed to something else in the healthcare field, such as a nurse or a physician assistant or like a dentist?
Yeah, I think that's more cultural. You either became a doctor or an engineer back home, and nobody dreamt of becoming a nurse. Now, it's totally different in the United States, and I can pretty much tell you that is because of the, what opportunities are there, and the respect in the community that a nurse gets in the United States, and opportunities, and they earn pretty well, quite well. That's not the case, unfortunately, in Pakistan. In Pakistan, and in other third world countries, everybody shoots for being a physician. So I do believe that some of that is cultural now. I can tell you, with my background of Pakistani American, that's how it was, but I know many of my relatives who are of that background, ethnic background, but they were raised in the United States. They actually do think about becoming a nurse or nurse practitioner. So again, I think is more cultural than anything else in the society. Doctor gets the respect. Well, that's here in other places too, but in West, nurses also get a good bit of respect and earning. So it's those factors.
All right, thank you very much.
Gotcha. So I know, Dr. Nayyar, you had a different experience in Pakistan in terms of medical school. But overall, I'd assume that the curriculum of all medical schools universally should be pretty synonymous. And so I'd like to ask you what medical school is really like. And a lot of people say that when you join medical school, it's like drinking water from a fire hose in terms of the quantity of material that you have to know. And so I wanted to get your thoughts on that. And I also wanted to ask you how your first year medical experience was, as you were a first year medical student. How was it different than you were as a senior in high school? And was there like a stark difference in the way that you had to approach your studies?
Yeah, it's a huge difference, and lots of hard work. I personally believe to become a physician, the #1 requirement is perseverance and hard work. And even someone like me who is not, an extraordinarily intelligent guy, I think so. But with hard work, you would do really well. Healthcare, is as simple as that. That there's a exam finding, for example, for inflamed gallbladder. So if you've read about it and it's called a such and such sign, if you read about it, you know about it. If you've not read about it, you don't know it, and you will not look for it. So it's a lot of study. And so that is true that it does feel like there's a world of knowledge out there that you totally were unaware of, and you just have to absorb as much as possible. So even in the United States, when I speak with my friends and they tell me their experiences, it's a lot of hard work. And I just think there's no corner cutting. I think you have to, if you dedicate yourself to be a physician, you should be willing to learn as much as possible. You know, many times I get the feeling that I wish I knew more. And then you think, if I knew more, I can help my patients even more. You cannot get to the deepest depth of the knowledge in healthcare. There's always something new to learn. So I think health people, students who join, who actually opt to become a doctor, they should just know that they're going to have to work hard. People around them will need to know that this person is going to be dedicated to their profession and probably be spending a lot of time, as a medical student and later on as a physician. So all of that is true. What you mentioned, that drinking out of fire hose, yes, but that's very good. And the more you can absorb, be like a sponge and keep on absorbing it and keep on working hard. Of course, a balance needs to be there. You need to exercise regularly to keep your senses and eat well, sleep well. But yeah, it is a lot of information, and you've got to keep on going, keep absorbing as much as possible.
Gotcha. Okay. Thank you for that answer. It's full of lessons. And so I wanted to transition to asking you, so we mentioned that the medical school experience is different both from here and in where you did it in Pakistan. So I was wondering if you could get into the details of your experience and how the International Allopathic Program, or the MBBS in Pakistan, and other places in the world, how is that curriculum structured? And is there anything particular or unique about it that makes it different, that you think might have helped you or gave you an edge over people or over students that you saw over here?
So that's an interesting question. Nothing to brag about, but I do think the style was important, and I'll give you background. So in Pakistan and India and those countries, it used to be exams were essay type questions. And it has changed now, by the way. Even back there, back home, it's multiple choice questions. But when I was there throughout my medical school, they were all essay type questions. So basically, we by the way, you were asking me in the last question, how was your medical school, studying and all that. Every day after the buses took the students to back home around 2 or 3, majority of the students stayed behind and stayed in the library, and we would study every day till 7 or 8 p.m. every day, and that's after a full day of school. And because it was essay type question and for exam format, we had to work hard extra, and we would race each other in reading the textbooks. So I'm in my office, and in front of me, I have my Cecil's Essentials of Medicine textbook from that medical school time. It's like you can tell it's been read 7 times. We used to race each other. How many times are you going to read your book? And what happened is every new reading, you learn something new, and as if you did not know that. Where is this coming from? So we studied hard, and we studied from Gray's Anatomy, which is used as a reference book, but we studied from it. Physiology, guidance physiology. We studied, we read the whole book and several times, and then several questions, the answers we memorized. I remember some answers were 17 to 18 pages long. The long journals, not the regular page size, the longer one, and you had to draw, a picture or whatever diagram, and if you want more skill, you colored it based on how things are in nature and label and all that stuff. I do think that memorization, there's drawbacks to every system, but that memorization and hard work gets you a deeper memory. And you can see examples of that in some of the religious traditions in Judaism and Islam, that memorization of the Holy Book, the more times you read, the deeper it went into your brain. Now, that is not to say MCQs are, not great. I think they're good, but it's a different way of learning things. Now, it has changed in Pakistan even. But so when I came to U.S., I was at University of Denver, Colorado, and I have that letter from the professor there, in fact, framed in my office. So I was at the university there, and I was a brand new graduate from Pakistan. And so I went to VA Denver, and I said, I'm here, I need to learn English because I need to be taking history very soon in English. And I've never done it in my life because history taking in Pakistan was in Urdu. Now it's totally different because history taking unfolds the whole diagnosis. If you cannot even communicate, you're not going to find out the diagnosis. So I wanted to get that mastery before I started my residency. So I went for, I asked for observation experience, and I did that. So after rounding, we would come back and the professor would ask questions to the class. Now, so I remember those days, he would say, what are the causes of dysphagia, for example, difficulty swallowing. Now, I had it memorized. And I need to add that what I was told by my friends that in the U.S., the school helps you a lot in the sense that there are notes you get. They're made from, different books and references and stuff, which is great because you're getting really good information. But we didn't have that support, so we had to read the entire book because there was no one making notes for us. So anyways, when I was in Denver, so in the morning report, they would ask questions. Now, if you don't have things memorized, you'll say important thing 1 or 2, And I remember Dr. Dunkelberg was his name, Jeffrey Dunkelberg, and he would ask questions, and I would have 10 answers ready for him because I had freshly memorized the whole book, Cecil. When I told the students at VA Denver that I read from Cecil, they said, we keep the textbooks for reference, but we have our notes. So that part I felt like, it was helpful because I remembered everything. Now, clinically, I didn't have access to patients as the students here do, but it only took 3 months to get that part. And then you already have the knowledge and you can begin to apply it. And it comes down to what you said, it's like a fire hose, and a lot of knowledge. And the more you get, the better you are. And in medicine, nobody can tell me that you will, if you work harder, you're not going to get benefits out of it. You're going to learn so much and you're going to apply it to your patient and you'll save lives. The impact of knowledge in medicine, as opposed to, not to downgrade a computer engineer, the impact of knowledge in healthcare is you save life, not a computer. And that's huge. So anyways, so that was the difference in style, and that was my experience. And after that, actually, he gave me a letter which I have framed. I can read the first line. He said, Nayyar's level of knowledge, he said, easily surpasses the best entering intern from University of Denver, Colorado, which is supposed to be a good medical school. And he wrote that letter for me. And when I sent that recommendation letter out for residency training, everybody asked me in the interview, how did you get that? What happened? So I think in retrospect, it was all from that style of learning that we had to remember so much. So there's good and bad, but that's my story.
Gotcha. No, that's definitely inspirational. Thank you for sharing that.
So reflecting back on your medical school process, what is one thing you would do differently if given a chance, or do you have any regrets about the process as a whole?
I think if we had more support in the medical school, and that's not something we can fixed. But few years later, we have Aachen Medical School, that came into existence, and they have the format there is just like United States. In fact, their graduates are really great because they have best of both worlds. I think, in my opinion, they have the memorization, and they had the American system. The education was American, based on American system, and so they had way more support. And back home, it's not that expensive, so it's not a financial suffering for the family or the student, and they're free to learn. So no, there's not anything I can do, but I think times have changed. It's good there now. It's better there, and yeah, so that's it.
Right. So in regards to your specialty, could you tell us a story about how you chose your specific specialty, including like the struggles and the insights, and if there was like an eventual flashbulb moment where it all made sense?
Yeah, so I was never thinking about hematology oncology. In fact, when I was internal medicine in Oklahoma, I worked as internal medicine doctor for a few years, and in fact, I would be scared of seeing. I used to be uncomfortable seeing oncology patients because they were on chemotherapy. Their blood counts are extremely low. Sometimes they had no blood counts, extremely sick, risk of infections, bleeding, and so. But a few years later, I began to learn more and more about bone marrow transplant. And I saw that they were curing people with cancer, not just treating. And that was very positive. So I started looking, where can I go and have some experience with in bone marrow transplant. So I found a job as a hospitalist in Little Rock at Myeloma Institute of Research and Therapy for Multiple Myeloma, where everybody on the hospital floor, was a bone marrow transplant, stem cell transplant patient. And they're probably the most complicated patients you will see in medicine ever. So I said, I'm just going to see what it's like. So I saw that. And there I realized that, it's actually really great outcomes. It's life-changing experience for some patients, a lot of patients, in fact. So then I began to develop this liking for hematology, oncology, and I think within a year and a half of that experience, I started sending out my applications, and I got, that's where I went to UTMB. And since then, I love my field. I tell everybody, if you are a people person, there's a lot of hand-holding and shedding tears with your patient. You have to let your patient know that you're with them and you feel the pain they have. Half the cure is your relationship with your patient, and it's now proven by some data, some analysis. There's, I think, a book that came out a year or two ago, I think by two professors from University in Pittsburgh, Pennsylvania, and they showed evidence that cure rates are 40 to 50% higher. Compliance is higher when there's a good relationship between doctor and patient. So anyways, so that's how I got into oncology, and this is what I feel like always needed to do.
Thank you for that. So now we're going to be transitioning into our second part of our questions. And this second part is going to relate to your experience as a doctor and as a physician. So our first question for this part is, so what does a typical daily or a weekly schedule look like for you? And could you elaborate on that?
Yeah, so my schedule is kind of different, but it's probably not very different from a typical small town doctor. What happens in a small town, most of the times you're the only oncologist in town. So if someone has been told by their primary doctor, the CAT scan shows a mass and it's likely a cancer, and I'll refer you to an oncologist. Well, on my side, if I'm very busy and I say, well, I can't do that for about a week or two, so I know, I feel the other side. The person is going through so much pain, knowing that there's a mass, but they don't know what is it, and is it something that can be cured, can be treated. So I don't let my patients suffer. I think if you choose to work in a small town, you got to work harder and try to see anybody as soon as possible. So as a result, I work really late hours. I work 4 days, Monday through Thursday, but I work till 9:30, 10, 10:30 every day to finish my notes, and I also have, sometimes there are consult requests at the hospital. So after clinic is over between 5:30, you either go to hospital, do a consult, and then come back to the clinic and do dictations. It's really different from bigger cities where there's a lot of backup. And if you had asked me a question, what would you do differently? Not differently, but my ideal professional life would be, and I tell my kids the same thing, and I'm telling my students, anybody who wants to listen to me, would be to be at a university hospital where you're teaching. So that's really great deed. You're teaching the students, and you can also carve some time for research, and you have your own clinic and practice. So you have everything: your clinic practice, you're teaching, educating people, and you're doing research. That would be my ideal life, but it's too late for me now. I think I'm too involved in my work here.
Right. So now could you elaborate on a specific patient encounter that you've had? And if there's like one specific encounter that you'd like to talk about?
Yeah, so, I thought about a case or two. So, for example, there's a patient I have. He is in his mid-70s. He was diagnosed with what's called lymphoma. Lymphoma is a cancer of the lymph nodes. And he was diagnosed 7-8 years ago. And he was heavily treated with several cycles of chemotherapy. But the first cycle he received of the treatment, he had severe reaction to the point that he was hospitalized. He passed out. He was hospitalized for several days. So the doctors at that time decided that this drug was too toxic, and we cannot use it again. So they kicked that drug out of the armamentarium to treat him. Now, that's a very important drug for his diagnosis. So for the next 7-8 years, they used other drugs that were toxic, but maybe not as effective without the one they had to kick out because of the reaction. But, they kept him alive. So what happened is, the lesson in this one probably would be thinking outside of the box. So anyways, so the patient came about 7-8 months ago. He was finally told, he goes to a university hospital in Dallas. It's like number 10 hospital, medical school in the country. And so nothing against anything, but it's just a different experience. So he was told there that so the cancer has progressed and we don't have any other options left. And so he went on hospice. They recommended hospice. Now, the drug that was used once 7-8 years ago and he had a reaction to was never used because of that risk. And I understand that. So anyways, his wife was my patient for something else. And she said, why don't you go and see my doctor? So she brought him to my clinic. And he gave me the whole story, and a very important drug called Rituxan was kicked out because of one-time experience. So I told him, let's talk about this. What if, let's assume that at that time they didn't know how to manage the side effects of that drug, and what if we do much better job, which we do, in managing the side effects of that drug, and you never received it? Would you be willing to take that drug and see if I can manage and not let you have that life-threatening side effect from which you almost died. So that's a big ask, right? You're asking someone to take a drug that almost killed him. But I said, I think we can manage the side effect, and it's a 4-hour long infusion. So we said we're going to do it over 8 hours, and every pre-medication to, curb the side effect will give you everything that's out there, 6 or 7 drugs, not just one drug, and see what happens. So I gave him that drug. He agreed, and he trusted me. Now, if you think about it, he's been heavily treated for 7, 8 years. He was at a university hospital. They said, go to hospice, and they said, you're going to die. You're expected to die in about next 3 to 4 months. And then here he was in my clinic, and I'm saying, take the drug that almost killed you. So anyways, just thinking differently. And he said, sure. And he tried it. He trusted me. We had a good rapport in the first visit, and I gave him the drug. And at the end of the day, he was like smiling because he had tolerated the drug and he had no problem whatsoever. We said that was a great moment for all of us. So I said, okay, let's go on and do 6 cycles of that. We gave him 6 cycles. We did a repeat bone marrow biopsy. There's no evidence of lymphoma anywhere in his body. He was losing weight. He had no appetite. He was all bones when he came to me first. This time, he is now back to normal life. And I think the lesson there is think outside of the box. That's number 1. Number 2, trust between you and your patient just makes a huge difference. And that comes down to being a people person and having love for human beings. And, you have to, when you come to healthcare, you have to dedicate everything what you have, and it takes a lot.
All right. Thank you for that. That was a very informative experience. So moving on to the next question. What are the more favorite and exciting aspects of your specialty, in your opinion? And what are the more mundane parts that are less enjoyable?
What are the more exciting parts of what?
What are the more exciting parts of your specialty, and what are the more like mundane or boring parts, in your opinion?
Of Hemonc, right? Yeah, so exciting part is it can't be any more exciting than giving someone life when they were waiting to die. And there are several other examples. I have on patients, several patients who were just ready to die over the next few months. And sometimes you fail, but if you work hard with the patient, with their trust, if someone lives 5 or 6 years when they were told that 2 or 3 months, that's a huge difference in impact that you have on their life. So that's the most important thing that I love about my field, because not everybody who has heart disease who goes to cardiologist is going to die. You can put them on blood pressure medicine, this and that, and they can go on for next several decades. Same thing with other specialties. And, oncology is different. You're not just talking about some illness. You're talking about to be there, to be or not to be. It's like, life or death. So that's it. The boring part, I don't know if I like all aspects of it. I'm into oncology, hematology. I don't know if there's very much boring. Maybe just minor issues, anemia, but that doesn't take very much thinking. But even there, someone severely anemic. I was just doing a meeting, consult to a patient who is in Austin, Texas, but she is a friend of one of my patients. So I did televisit, and I guarantee you, when she receives intravenous iron, she had no idea that she's iron deficient. Her life would change because she sleeps all the time. She has no energy. She has a lot of other problems, muscle cramps, craving, this and that. So even though anemia is kind of boring, but even that sometimes can be exciting. So not very much a boring aspect. If you love this, you pretty much like it all.
Gotcha. Thank you for that, Dr. Nair. I mean, the stories you shared with us are like incredibly like life-changing and like inspirational. And so I think they really paint a good picture of not only the challenges you face in hem-onc, but also the triumphs that you have. And so speaking about challenges, I wanted to ask you a little bit about um, an overall question of what are the biggest challenges facing your specialty as a whole? And what do you think your
Mhm.
specialty will be in the next 10 to 20 years?
Yeah, so I think overall, I think this question comes from what's the future of medicine, I think, and a lot of people are concerned about, AI and Watson. What I have seen, and there's a book published in this on this topic, that there will be some specialties that will see a change, and what people are discussing is probably radiology. There will not be a need for as many radiologists because the computers are very good in reading, and they're like, if the rate of mistakes in reading a film by a human being is like 20-25%, computers mistake rate is like 5%, 4%. So that doesn't mean that we will not need any radiologists, but that what that means is they'll probably at some point push all the films through the computer first and bring down the rate of, just I'm making up these numbers, from 25% to 5%. And then a human would look at them and bring down that 5% to maybe 3%. It will make the job of the existing doctors easier, but there will probably be need of less radiologists. Having said that, as a background, I don't believe that, that's my personal belief, that oncology would change very much. It's a field where there's a lot of hand holding and sharing tears and person to person. It doesn't matter how much technology advances, a human touch is required when it comes down to life and death. Now, the other aspect of what changes one can see, the other one I can think of is the telemedicine. Now, that probably will happen. So when COVID-19 is over, I do believe that at some point, if not right away, I think there will be options. People will have option to talk to an expert in China while they're sitting here, or Germany or France, or a patient in Germany will have an option to speak with me or somebody else and get my opinion. But again, in oncology, and maybe the blood disorders can be diagnosed remotely and treated even remotely. But pure oncology, solid tumors, lung, breast, liver, colon, pancreas, I think that will not change very much. Now, one more aspect is there's so many aspects to the answer to your question. Another change I see, that I do believe that oncology at the verge of big change. A big change. Just 1 second. 15 minutes. So oncology is at the verge of a big change. It's coming. Right now, more than half of my patients are on immunotherapy and not on chemotherapy. So chemotherapy makes people sick. But immunotherapy is, if you want to put it this way, so natural in its mechanism that we kind of crank up the person's immune system, and your immune system fights the cancer. So I see that trend more and more. More than half of our patients in some centers are on pill targeted therapies. We're inside the cell now. We are looking at receptors on the surface of the cancer cells. And they say in a human body, there's average somewhere between 50 to 75 trillion cells. And if you draw a dot, they say it's about 1 million cells. Now, that dot is 1 million cells. So 1/1,000,000th of that dot is a cell. And on and in that cell, there are receptors, and there are medicines that are blocking those receptors. So you can see how deep this goes. So a lot of treatments are changing, and they're becoming very targeted. So on one hand, we have targeted therapy. So oncology is only getting to get better and better in treatment, in sense of treatment. And on the other hand, we have immunotherapy. Now, what's next is CRISPR with gene editing. They're already working on some of the conditions that are genetic, purely genetically driven, or chromosomal alteration driven. So if you can edit a certain gene by CRISPR, you eliminate the entire, pathology. So that's what's coming in terms of treatment. So I do believe in the next 10 years, 5 to 10 years, there's going to be a huge change in oncology. So in terms of treatments, what's coming up is changing. In terms of how we practice telehealth and use of AI and that. But at the end of the day, I think all of these aspects are only good things for the patients. One patient of mine asked me the other day, he said, "What are you going to do when cancer is cured?" I said, "I'm gladly going to go to some other specialty." If it's you today, I said, it could be me tomorrow, because everybody is going to have these illnesses. As you know, a king or queen or prince, doesn't matter who they are. If they are to have a cancer, they are going to have it. So the question, a lot of times, I used to think, most of us think when something like that happens, you say, "God, why me?" What I have flipped that to say, why not me? Why am I so special? Or any human being is so special to not have it. So we're all vulnerable, and things are going to happen to all of us. Maybe, maybe not, but it's not in our control. So in any case, so patient outcomes and treatments are improving. That's just good for humanity. That's what's changing over the next 5 to 10 years.
Gotcha. Okay, very interesting stuff. Segueing off the patient outcome that you just mentioned, I imagine that you have a bunch of chronically ill and terminal patients coming to you because of your specialty and what it exposes you to. And so I wanted to ask you personally, how do you manage the stress or the sadness that accompanies that? And what advice would you give a person that's just starting their journey of how they should manage theirs?
Yeah, so if you are joining healthcare, first of all, not every field is like oncology. So if you're asking a general question, cardiologist is not seeing all of that. The majority of their patients are doing great. Internal medicine, oncology, oncology is different. But I can tell you an example. When I was briefly at MD Anderson during Hurricane Ike, the head of the department of the pancreatic cancer gave a talk. And he said, he was giving us an example. He says on weekends, he had a Corvette. He said he would park his Corvette away from his house. He had an acre or two. And he said, and he'd be cleaning his car. But actually what he's doing is he's staying away from everybody, and he's just crying. He just cries and sheds his tears. He said his wife would look through the window, in his house, and she would see, oh, he's cleaning his car, washing his car. But he said, many times I'm just getting it off my chest. So it is natural to be saddened by it. In the olden days, 20, 30 years ago, they used to kind of tell the doctors, and you're the strong guy or girl, and you're supposed to not show emotions, and you got to protect your patient. And if you're emotional, then your patient is going to not feel good. That's not what is taught now. Now we're told, and I did that even before this became, a common thing or ideal thing to do. Just show your emotions, that you're a human being. So, there's so many times you sit with a patient, you shed tears with them. It makes them think that, you're with them, and sense of team. Of course, not to an extreme that you're to the point where patient has to take care of you, but just be natural and show emotions, and it's perfectly all right. Now, it is true that it puts a lot of burden on you, and there's a high rate of depression and suicide and all that. I think oncology has the third highest, I think, after ER and psychiatry. So you have to find things that will help you, and there are studies that show being involved with the family and friends, having community, and regular exercise and sleep and eating well. I know it sounds minimal, simple stuff, but those things really make a big difference to protect yourself naturally. You know, community, association with people, and exercise and eat well and sleep well. That's what I try to do. I get my antidepressant through my running and my workout. It truly is, exercise and running is, for me, as an antidepressant. I totally change after the workout how I feel. So you have to save yourself.
Gotcha. Thank you for that.
Thank you very much for all your answers so far, Dr. Nayyar. So as your final question, as your wrap up, what is one thing you would like to say to people who are just starting on their journey to become a physician?
Yeah, so most of my friends happen to be physicians and surgeons, and I've heard a lot of them telling their kids or talking about it that, oh, when my kid asks, I tell them, oh, don't go to healthcare. There's no more money. So I hear that all the time, and I feel like countering that, but I don't. But I can always tell my kids and my friends and my youngsters how I feel. First of all, if you want to be in healthcare, get it, out of your mind that you're going to make tons of money. Because if you're disappointed, you're going to hate your field. Join healthcare because you want to do it. If money comes, great. If it doesn't come, there will always be enough money that you will be making more money compared to, let's say, for example, an MBA and an engineer. And on average, I'm not saying exceptions are there. You will, even if they take out, 50% of what people earn now, you will still be earning fine. But important is setting the expectations. Don't join healthcare that it's going to be money making and this and that. So come into the field because you love it and you are a people person and you want to do things for others, because it's really for others. You're not doing very much for yourself when you're seeing patients. And what I tell my kids is always have a goal bigger than you. Because if you have goal bigger than you, meaning doing things for others, you will end up having a lot for you as well. But don't have that as a goal. And there's a satisfaction that you derive when you do things for others. And one of the ways they say, if you're going through some sad times, one of the ways to counter that is to start helping others. And that helping other act relieves your pain and suffering. It's a very well known phenomenon. So join healthcare because you really wanted to be in healthcare, have a bigger goal in life, bigger than yourself, and don't have any expectations. What comes your way, it's gonna come anyways. Doesn't matter what you do, but at least have the right intentions.
Gotcha.
Right, thank you.
Yeah. Thank you so much, Dr. Nair. It's been an absolute inspiration to talk to you about your specialty and all the struggles, but also all the triumphs and celebrations that you've had with your patients. And thank you for providing that example of that specific patient and how taking a risk and thinking outside of the box really proved to be life-changing and life-saving for them. So I just want to thank you so much for joining with us. Your advice has been invaluable, and I know that you probably have to go see patients or do charts and stuff. So I want to be able to let you do that. And so I want to thank you, and I want to thank everybody who listened to this. And I want to ask everyone to please like and subscribe to this channel. And you can claim your credit below, by the Shadow credit below, by clicking the link. And please join our mailing list so you get to know when we talk to more physicians in the future. And so I hope to see you guys next week. And thank you everyone for joining.
Thank you.